as a name. So we think we're still in morning. Good morning, everyone. Dave Howden from Umbrella. You're only going to get to see my face for a few minutes because the main meat and potatoes of this content is going to be delivered by this man. But I think it's worth just highlighting why we are here and why it's important that we are showing the content that we are today. We were actually here 12 months ago. And 3 weeks out from hiNZ 12 months ago, we laid down a bit of a challenge for ourselves to actually deploy a meaningful business intelligence model with a live data set across the Mercy Radiology data set, which we've just been appointed as the cloud service provider for. And we showed the fruits of that labour over the course of 3 weeks. But we're now 12 months and 3 weeks on, and we've actually really modified massively the amount of value that we're delivering back to that organisation. Dalibor is going to walk you through not just the context about what the insights we've delivered back to the organisation, but actually when you want to deploy a meaningful set of business intelligence or clinical intelligence across the data sets that your organisations may or may not have, actually what gets the value delivered at speed and with velocity, to make sure that we deliver value as quickly as possible. So that is as much value that I can deliver to you today, but you're going to see some great stuff over the course of the next 14 or so minutes. So Dalibor, I'll hand over to you, sir.
Thank you, Dave. Hi everyone, so my name is Dalibor. I'm the director of Aceso Healthcare. We're at the Umbrella stand. Look for the beautiful cloud, and beautiful clouds is in many ways what this presentation is about. So I will give you the very quickest of introductions about our company for those of you who don't know who we are. We are a solution provider to the healthcare industries in New Zealand, Australia, the countries of Macedonia and Serbia, and Ireland. We have customers internationally as well, but those are the main kind of markets. So, here. We'll get there. The forward arrow does not like me. Sorry, guys. This one? That's it. Fantastic. It's the kind of technical savvy that we would hope is the technical savvy we expect from the CSIRO. That's excellent. So, if I can leave with you 3 takeaways for today by way of framing the talk. So, we'll tell you what happened, as Dave said, after a year of Mercy Radiology using the work we did in just 3 weeks. We'll talk about how that was possible and what that means more broadly, and the implications for security, privacy, and other controls, which are relevant to a current customer, and I'll talk a bit about that. I work with them, which is Tora Compass Health, the PHO in Wellington and the surrounding region. So 1 year ago, and this is a pretty great result, if I'm allowed to say that on stage. 1 year ago, we deployed a series of dashboards. This is just the most kind of fancy one because a lot of the mapping and geospatial work was delivered here operationally. We deployed this for the Mercy Radiology Group in Auckland. And in that time, the growth has gone from 15% to 30%. Basically, and they're a commercial organization. I mean, we're here for health outcomes and improved patient outcomes, but private companies do a lot of that work in New Zealand and internationally, and the commercial imperative that they have is not just to make more money, it is also to deliver more care. And we can definitely confirm that this is happening at Mercy Radiology. So, historically, for a few years, the radiology's revenues were growing at about 9%. Lloyd Cann and some of his kind of crack management team took over in 2016 and accelerated that to about 15%. They obviously knew what they were doing, or there would not have been an acceleration in growth. Powered by the right BI, they've been able to double that. Now their biggest problem is growing too fast and not how to operationalize data. And this took, I'm sorry, Ron, you are now awake. And this took 3 weeks. So how do you get it done this fast? And I want to say that getting BI done quickly is not the challenge it appears. And we can tell you stories about if the right conditions are met. And we can tell you stories about this on clinic level scale, Mercy Radiology is one example. We've worked with IMED in Australia, which has about 230 radiology sites. We've worked with Centric Healthcare, a network of 50 GP practices in Ireland, to very, very rapidly deploy BI outcomes. We're now working with Tuora Compass Health, who have their own BI team. The BI is not what we're providing the infrastructure, and what that means I'll show you in a moment. But we were aware of and have helped, have understood the data set and have helped them work out new ways to work with that data set. At the national level, and these are large data sets here, we provide a platform called Pinga, and I do encourage you to visit our store and see this in action, for the countries of Macedonia and Serbia, who between them have 10 million patients. So there are 10 million patient records that start from primary care through to prescriptions, electronic referrals, basically every hospitalizations, the entirety of a person's shared care record that you would expect in a fully integrated example is available to us through the platform Pinga, and we provide the analytics and BI for this, or the infrastructure to do it, for the governments of those countries, or strictly speaking for their ministries. So what does it take to do BI quickly? And if there's one major takeaway that I can leave with you, and hopefully you'll take back to your organizations, is you have to have a source of truth. BI platforms can support integration of multiple tools, and everybody says data lake now, where they used to say data warehouse, maybe they said spreadsheet before. It's got to connect in one unified place. Otherwise, you trip over your own feet trying to figure out what dashboard will combine with what other one, and then there's some bad data here. And just in the previous talk, we heard about the incredibly sporadic data that a lot of PMSs have. Unless you can combine your data into one place, and it doesn't have to be perfect, you will find the imperfections when it is combined. This is what it takes to rapidly do something, because with tools like Power BI, which is the main tool we use for data visualization today, and some of our own tools, you could throw a dashboard up so quickly if you have a good data model. And a good data model is of no value unless data is coming from a place that is not necessarily connected with this data model and now plugged into it. So the team at Tuora Compass Health, and I'll talk more about that in a moment, have created in many ways a shared care record data model. Technically it's not a shared care record. There are things that don't go in there. But taking 60 PMSs or 60 clients with their own PMS, some of them may be the same software, but they've all done it their own way, and turning that into a single source of truth means that the BI team can work extremely quickly to create new reports. This was the same at Mercy Radiology. They had the advantage of having one consistent RIS serving all of their 12 clinics, which meant that we could just work on that data, fix it, because data, as you know, in healthcare is frequently atrocious, and quickly deploy visualization. At a national scale, BI is a very simple exercise for the ministries of Macedonia and Serbia, because they have one enormous ready-to-go database that has been optimized for quick querying. You'll see some of that at our stall. The Serbian government has a dashboard, and this is publicly available, where they can watch people get healthcare in real time. There's a little blip whenever a prescription is issued. As you can imagine, around lunchtime, it's just firing all over the place. There are loops that tell them a referral just went from this town to the same town, or across. You'll see a picture of that. Sorry, I should show this. This is, in fact, this dashboard. So this is how many prescriptions have taken place in a given day, referrals, GP appointments, and these dots just carpeting this picture. These are referrals electronically being sent from one place to another and bookings being made. Come see this in real time. It's not very exciting because it's now basically the middle of the night, but we can look back at what happened yesterday and you can see some interesting animation and thing. So I just want to reinforce the concept of a single source of truth. If you have one database you can query, this is possible. Modern healthcare organizations, particularly in Western countries, do not necessarily have this. But the challenge should be to create it, not to try and hack something together. And once you're close, you can close the loop, and put some BI on top that begins delivering results immediately. You know, we spend a lot of time hearing these health and AI pitches. Getting the data in place is the key. So, at Tuora, the PHOs, and Tuora especially, already have truth. I just want to make an apology. Our font doesn't look good, but Tuora has a bar across the U. So please accept my apologies for that. So PHOs are already getting this data, as I mentioned, and the BI team knows what they're doing with it. But we're now moving to a unified model of care where people are logging into platforms, getting reports online. If every GP practice needed some reports, lists of their patients who smoke, a lot of them actually can't get this from their own PMSs. And even if they did, it wouldn't be useful enough because they need it to be connected with other data that the PHO has access to. So the PHO gets these requests and has to process them. It's an enormous job. At the moment, Tour Compass Health is going through an enormous technology transformation being led by the team internally and for which we are providing a certain amount of solution delivery. That transformation includes the ability for all reporting to be delivered directly through our application Pinger, which will serve as the provider portal for their network. This gives enormous power to the BI team. All the reports they've been making historically can now be directly served to users. Those reports can now be made once. So a report says practice report. There's a very kind of toy example. Dipan over there can tell you more, who's from the PHO. So there might be a practice report, and it has certain data that's relevant to the practice. It's powered by Power BI, so they can click, all right, smokers, give me a list of my smokers right here in the browser. I want to show you this today. Unfortunately, technologically, it's not possible in these rooms, but please do come to the stall. You will see this click through and all sorts of fancy pictures. So rather than make the smoking report for practice A, B, C, D, we're going to run out of letters in the alphabet. There are 60 practices at Aurora. They make one report. We validate the identity of the user, and they get access to their report. They didn't have to download it. They didn't have to go to a different place. The BI team didn't even need to make a different report. They've got a single source of truth that knows what people are, where they've come from, and who is a smoker. And the practice report has a filter for smokers. You click it. Here's the data. This sounds very complicated and is actually far simpler than it appears. You need a source of truth for identity and for data. For security reasons, we separate these. And you need a place to view it where you have powerful enough tools to set this up. This is what is being deployed at Aurora at the moment, and please do come and see this in action. You'll see a picture of it later, but it's much more exciting when we can click on it and actually show you these things working. So basically, we've deployed this together with Umbrella, leveraging some of the capabilities of Azure that makes this very easy. The cloud means that you can pull all the data into one place. We're using Azure SQL for this. Active Directory allows you to have a single source of truth for identity, separate to the data, but obviously connected. And we can now implement something called row-wise security. This is kind of the holy grail of security for data access because people can be logged onto a platform and there is no way through a wall to get data you're not supposed to have access to because there's nothing there. The system has only provided you with data that you're allowed to see. Just imagine this in your organization. This is a top-level dashboard that you can actually view online now. Again, come to the store and have a look at it. We'll click around and show you some filters. This is using 150 million occasions of service, hundreds of millions of data points across the Republic of Serbia. And we can just browse by specialty, by disease. At the ministry, they can dig this down to the statistical area or even deeper. The publicly available data is obviously a bit more aggregated. At the PHO, a user will have a role. I'm a doctor. I can see my practice. I own 3 practices. I can see the practice where I'm a doctor and the patients and get business information about the other 2. The team have only had to do one report. And just in closing, I'd like to kind of wrap up our mission. We really believe that the outcomes that we have seen and helped deliver internationally can be brought to New Zealand and deliver a powerful result for healthcare here. We know what is possible when you put data together and when a business is driven by fact. A business can be a for-profit company, it can be a national health system. Enormous results are possible. Thank you. I've had some time warning, so thank you all very much for listening. Please do pop by. There's a cloud that says Umbrella, and you'll see an Aceso logo as well, and we're down there and happy to show you more.
Thank you very much, Dalibor. Our microphones are working. We are at full flight. We have 5 minutes for questions for Dalibor. If there's anything, first of all, I'd like to say fantastic presentation, and I'm very impressed, particularly what you're doing in those countries. And my question for you is, what do you said that getting the data right is the key. What recommendation do you have for us in New Zealand? Like, what should we do with our data? Because at the moment, this is a hot topic.
Well, you have my honest opinion and my public opinion. My honest opinion is build a national shared care record that contains everybody's information in one place. It doesn't have to be insecure. There are ways to do this. We've done it. So that whole WannaCry incident that happened a few years ago, this didn't even touch Macedonia and Serbia. The cloud is the way that you get the security right. The minute things are dependent on client-server applications, access points proliferate, holes exist in the system, you can hide a central source of truth from any public access that is not heavily mediated by a piece of software. Publicly speaking, this requires national interest, and we did have the DG over at the stall yesterday, and of course pushed this message very aggressively. But there are viable shared care records around New Zealand that are just not quite closed. The South Island has great stuff, but it's in two disparate systems. These can be connected. Every PHO has a magnificent source of truth, already dealing with the problems of filtering and creating a shared care record. If this could just be connected with the DHBs, one comment that was made in the previous presentation in Sankalp, imagine if you had fully integrated data for every primary, secondary, and tertiary thing that happened to a patient. These data sets exist. They can be integrated locally because people don't move around that much before they get to the whole New Zealand stage. One PHO, DHB, or 2 or 3 of them working together is enough to build a spectacular use case for this. I think we'll get part of the way there at Tora. What the team already does is phenomenal. With this infrastructure that we'll put in place, I think we'll see some really cool stuff. Hit me. The question pillar.
So yeah, look, I know there's efforts in different places trying to do that. There's a lot of other issues that come in when you're talking GP data and things and ownership, and there's an effort on the GP data side also happening in Australia to sort of to do that. But in your view, where does using that whole free text versus structured SNOMED type stuff, where does that fit into your thinking?
So, the country has roads. Most highways are built or funded by government money, and the government decided that we all have to drive on the left, or in certain countries the right. So, I think it is the responsibility of the regulatory body to say, we are going to mandate a certain set of metadata. In Macedonia and Serbia, this was ICD-10 coding. And I know SNOMED is much deeper and more advanced. From our perspective as a software provider, we take one table of ICD-10 codes, swap it for SNOMED, or have both and map them. It doesn't really matter. But there was a mandate there which said, in order to send an electronic referral, it has to be attached to a diagnosis or a prescription. That diagnosis has to be ICD-10. So when the system launched, there was a catastrophic outbreak of cholera in Macedonia because the first ICD-10 code, A00, is cholera. And the country hasn't had cholera for like a century. So after some wrists were slapped and some aggressive eyebrow stares from the ministry happened, suddenly cholera was cured. Jon Snow back in action. So I think it is should be the responsibility of the regulatory body to say, to create the shared care record, these various pieces of metadata are mandated, and start simple. Once the vendors and practices and secondary and tertiary providers are kind of speaking the same language, once everybody's driving on the left, now we can build highways where we will not have 200-kilometer-an-hour head-on collisions. And the standards for communication are good, like 807 and FHIR. They lack an enforcement of coding standard or informational standard. And the biggest problem in healthcare is always that everybody wants to solve the whole thing at once. For example, historical records in Macedonia, day one, didn't exist. Turn the system on and start electronic referrals and prescriptions. Later we're going to backfill, scan, feed it in, do this, do that. You've got to do one move forward. You cannot go, this bridge too far, since I heard it this morning in different contexts. You cannot go too far too fast.
That's a huge debate, but we'll do that later.
Yeah.
So, do you mind just waiting for the mic?
There's a question pillow that
So did you cure the cholera in the data that you had?
Compliance is exceptional now.
Yeah.
We can.
No, I don't mean compliance. The rubbishy data that came in
Yeah.
that was coded cholera, did you address that or did you leave it? Does Macedonia still have a historical
Little
cholera
cholera
issue?
spike? I actually don't know. I think they went back a few months later, fixed it. But one of my colleagues, Mariana, can tell you more about that. Who was at the ministry at the time. We started in Macedonia and then deployed the same system in Serbia, for which the ministry graciously seconded some of their experienced deployment staff to help deliver this, and then we hired them.
Because I think
apologies to
you're
the
making
ministry.
a really important point there, that usually when you do implement change, and even in a medical setting when staff, new staff start, you do get errors and
Yep.
they don't get fixed later. And it's really important if you're wanting to do business intelligence, I believe, that you know where the human error things are.
It is, but I will just make a comment there. If Macedonia has a little blip of cholera from 2012 still in the records, it is irrelevant for any public policy today. I think they fixed it. But bad data is bad, and errors are bad. But an error like 30 referrals for a prescription, which is obviously for the flu, to say cholera, isn't going to kill anybody today. There is an aggression about perfect data which can inhibit change. You have to eat some of these errors during transformation, and the system, once it is set up, will trend and tend towards the right kind of data. There has to be continuous pressure from a regulatory authority to say, this is how we talk now. This is how we're going to communicate so the mistakes do not happen in future. Otherwise, new CEO of a hospital, new director, new CIO, the new standard now, everything is new. You have to have a mandated structure.
I agree with you. So as long as people know the story behind the history of cholera in Macedonia, you're okay. I do agree with you there.
Thank you very much. Unfortunately, we're out
Please.
of time. Oh,
I'm
it's just
joking,
supposed to
no,
be the
no.
speaker.
I just wanted to elaborate on your point, actually, because it's a really interesting one. And the first time we started working with the Aceso guys in Dalibor, he was talking about data commentary. As the fact is that having someone that knows the blips in the data is actually really, really important. So weekends, that's why it drops there. Christmas periods, why do people break more wrists when it's cold? You can't see that in the visuals, but you know instinctively because of what it's showing you, and that will be one of those.
Training.
So data commentary is as important as what the visuals telling you, right?
Absolutely.
Good point. Thank you very much, and let's all thank Dalibor.
Thank you very much.